All right, let's dive right into this clinical explainer. We're going to take the complexities of bipolar disorder and break them down into a really clear, actionable, evidence-based nursing framework. If you've ever felt totally overwhelmed by all the moving parts of this topic, don't worry, you're in the right place. We're going to map out exactly what you need to know, both for your clinical practice and for those high-stakes exams. So here is our game plan for today. We'll start with understanding bipolar disorder, look at the etiology and risk factors, break down the types of bipolar disorder, spot the clinical manifestations, and then jump into nursing assessment and interventions before wrapping up with safety priorities. Section 1. Understanding bipolar disorder. Let's establish exactly what this condition is right off the bat. The absolutely crucial word to lock onto here is chronic. This is a chronic condition of alternating extremes. We aren't just talking about someone having a bad week, right? We're looking at reoccurring episodes where perfectly normal periods of wellness are completely hijacked by severe mood swings. These episodes usually show up first in adolescence or early adulthood, and they can profoundly, literally derail a patient's social and occupational life. Just imagine trying to hold down a job or maintain a relationship while your brain chemistry is aggressively pulling you between absolute, unstoppable euphoria and just crushing despair. That's the reality we're dealing with. Section 2. Etiology and risk factors. Let's look at the underlying triggers. You know, what's genuinely fascinating here is the multifaceted brain involvement. It's like a giant biological puzzle. It's not just one thing. It's this complex combination of genetic predisposition layered with a massive monoamine imbalance. We're talking dopamine, serotonin, and norepinephrine all out of whack. On top of that, we see GABA dysregulation, a disruption in neuroplasticity, and actual physical, structural brain changes in the hippocampus and amygdala. Oh, and don't forget neuroinflammation from pro-inflammatory cytokines. The brain is quite literally under immense biological stress. But biology is really only half the story. A patient's genetic vulnerability usually sits dormant until it's activated by specific environmental risk factors. Think of a family history as loading the gun, but things like severe sleep deprivation, intense psychological stress, or pure physical exhaustion, those pull the trigger. Throw in alcohol, substance use, way too much caffeine, or underlying neuroendocrine disorders, and you've just created the perfect storm for a mood episode to hit. Section 3. Types of bipolar disorder. Differentiating these is a total must-know for your assessments. So there's a really stark contrast between the two main diagnoses. Bipolar I requires at least one full manic episode, which usually alternates with major depression. And because that mania is so severe, hospitalization is almost always required. Bipolar II, on the other hand, is characterized by hypomania and major depressive episodes. The absolute defining line you need to remember, there is zero psychosis during hypomania in bipolar II. That is a massive, game-changing distinction for your clinical practice. Now, outside of the primary two types, you've got to recognize these other classifications. First up, cyclothymic disorder. Pay attention to the timeline here. It requires at least 2 full years of fluctuating hypomanic and mild depressive symptoms. It's lower grade, sure, but it is a highly persistent, exhausting roller coaster. Then there's rapid cycling. This is incredibly taxing on the patient. We're talking about experiencing 4 or more distinct mood episodes within a single year. Section 4. Recognizing clinical manifestations. Let's see what this actually looks like on the floor. Okay, if you write down one thing today, make it the dig fast mnemonic. It is your ultimate key to quickly recognizing mania. Let's walk through it. D is for distractibility. I is for indiscretion. Think really poor judgment and risky behaviors. G for grandiosity, that intense euphoria. F for flight of ideas. A is for increased activity. S is decreased sleep. And T for talkativeness. Mania can escalate incredibly fast, and in bipolar I, it can also bring along severe features like deep impulsivity, psychosis, hallucinations, and delusions. Now compare that full-blown mania to hypomania in bipolar II. For it to be hypomania, it has to last at least 4 days. These patients will have a huge surge in energy, skyrocketing productivity, and they just don't feel the need to sleep. They might feel wildly creative with elevated moods, pressured speech, racing thoughts. But again, there is no psychosis. And because they often feel fantastic during this phase, they usually aren't hospitalized. And honestly, they're often very reluctant to even seek treatment because they like how it feels.
But then the pendulum inevitably swings back. In sharp, sharp contrast to the high of mania, the depressive episode brings this crushing weight. You'll see persistent sadness and anhedonia, which is that total inability to feel pleasure. You'll observe profound fatigue, severe psychomotor slowing, poor concentration, and major hits to their appetite and sleep. Hygiene often completely falls off the radar. And crucially, this is the phase that carries a life-threatening risk for suicidal ideation.
Also, when you're assessing these patients, you can't view bipolar disorder in a vacuum. It doesn't usually happen alone. They very often present with concurrent comorbidities. Anxiety disorders and substance use disorders are incredibly common here. You might also be dealing with ADHD, borderline personality disorder, or even physical stuff like severe migraines. These comorbidities complicate the entire treatment plan, so a holistic, big-picture assessment is absolutely non-negotiable.
Section 5. Priority Nursing Assessment and Interventions. This is where the rubber meets the road. As a nurse, you are constantly bombarded with data, right? So you have to know how to prioritize. Your assessment must systematically put safety and suicide risk above all else, period. That is always number one. Follow that closely by monitoring their mood changes, thought processes, and speech patterns. Then you've got to evaluate the physical basics: sleep, nutrition, hydration. Finally, assess their judgment, impulsivity, and overall medical status. So, once you've assessed, what do you actually do? To stabilize a manic patient, you need to immediately create a low-stimulation environment. Dim the lights, turn down the noise. You have to actively protect them from their own impulsive behaviors. And here's a pro tip. Manic patients rarely sit down long enough to eat a meal, so you must provide high-calorie, nutritious finger foods, things they can eat while pacing the halls. Cut out caffeine entirely. And behaviorally, set firm, rock-solid limits using very calm, short, and simple communication. Don't argue with them, just state the boundary.
Section 6, Safety Priorities and Key Takeaways. Let's bring it all home.
These safety priorities right here, they are your mandate. You must proactively monitor for escalating behavior. Do not wait for a crisis to react. Always, always maintain the patient's dignity and privacy, especially when the illness is making them act totally out of character. Instantly remove any dangerous objects to prevent injury. Keep them under continuous observation if you have to. And remember, restraint and seclusion policies are an absolute last resort, used only when clinically indicated to prevent imminent harm. To tie this whole clinical picture together, take a look at this comprehensive visual cheat sheet from FoxRN Academy. It's a fantastic summary. It perfectly maps out the clinical features, gives you that dig fast mnemonic, and ties every single piece back to your direct nursing interventions.